justice. I was like,
open up the room. So we'll be live here shortly.
okay, perfect. Thank you.
Mhm.
Welcome in, everyone. Thank you so much for joining today. We can give folks a few seconds to come on in, and then we will begin. Welcome in, everyone. Thank you so much for joining. We'll just give folks a few more minutes to join in, and then we'll go ahead and get started. All right, we can go ahead and get started, and then let people join in as the beginning few minutes go on. So again, thank you everyone so much for joining today. Welcome. This is our second to last ED Stop Suicide QI collaborative session. We are so happy to see all of you here today. We can go on to the next slide. So the EMS Children Innovation and Improvement Center is funded and supported by the Health Resources and Services Administration, also known as HRSA, within the Department of Health and Human Services. The Pediatric Mental Health Care Access Technical Assistance Program is also supported by HRSA. The contents are those of the authors and do not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the U.S. government. Next slide. Nurses and social workers, please remember you must put your first and last names into the main collaborative session chat feature. Use the link given at the end of the session to complete the session evaluation to secure contact hours and CE. The before and after breakout group portions of this session are being recorded and will be posted online to the EIIC website. Also, please note that this is our last session we are doing breakout groups in. We are going to start out in the large group with a presentation from Mona Thompson on how QI strategies and its iterative nature leads to sustainability, directly into a brief presentation from Dr. Cheryl Yanger on sustainability planning strategies and maintaining engagement within your site. So a little bit about our speakers before they begin. Mona Thompson serves as the Principal Project Manager for Quality Improvement at Rainbow Babies and Children's in Cleveland, Ohio. In her role, she coordinates and manages the evidence-based practice and guideline program, the Pediatric Asthma Clinical Effective Team, and the Pediatric Sepsis Collaborative. Mona uses and teaches quality improvement science daily in her numerous quality initiatives. The majority of her work is collaborative, multidisciplinary, and outcome-driven. Dr. Cheryl Yanger is one of our EIIC collaborative domain co-leads. She is an assistant professor of medicine in the Department of Pediatric. Cheryl also is the quality director for pediatric emergency medicine at Dell Children's Medical Center of Central Texas with the University of Texas at Austin. After these brief presentations, we are going to split off into our breakout groups for about 45 minutes to discuss sustainability planning ideas or next steps that groups are planning on taking with their teams and QI projects. We'll join back together for the remaining 20 minutes to hear about some next steps that groups are thinking about taking to move their project forward. Please stay until the end to complete the session evaluation poll. And for any questions that you might have throughout the session, please put them into the Q&A chat feature and we'll get those answered. Next slide, please. Here are the formal objectives for today's session. And with that, I will turn it over to Mona. Thank you.
Hi, thanks so much. Thanks everyone for having me, inviting me to speak today. I'm just going to talk, as Eleni said, just about 10 or 12 minutes talking about QI science and how we can use implementation strategies, QI strategies and iterative process to improve care. And then, as you said, I'll turn it over to Dr. Yanker to talk more about sustainability. So the image that you're seeing here right now, you may or may not have seen this before, and I'm not sure if the group has shared this in the past, but this is, I think, a really cool visual to think about where we are right now. So here you are today representing your organization as part of a learning collaborative. What you're coming to today is you're learning some things from your if you look to the right, it says external. So you're really coming together today to learn and talk and share about how other hospitals that are part of this collaborative are taking information taking information that's being shared with them, or potentially taking information from some of the evidence-based bundles that have been shared with you. And how are they taking that information, and how are you then taking that back to your organization and thinking about how you're going to implement those bundles or those different practices. So you see the yellow arrow comes in, you're identifying problems and potentially innovative solutions. And what you are really being tasked to do, or I believe you're being tasked to do, is take that information and think about how can I take it back to my organization and make it work? How does that fit for us? Because we know that every organization practices a little bit differently, has different setups. So you can't take a specific initiative and implement it as is, right? It needs to fit into your system. So you're going to design that, test it, implement it in a number of different ways. You're going to use PDSA cycle, which we're going to talk about, make adjustments, evaluate it until that works. And then hopefully you'll come back and share with this group again or share with others and how that works for you. So really, that's just a lead into what we're going to talk about today, which is that first, or what I'm going to talk about, which is the first objective. So if you go to the next slide, this is just, again, a visual that we're talking about, the model for improvement. The model for improvement is just one of the many different frameworks that people can use to improve care in their hospitals. The model for improvement comes from the Institute of Healthcare Improvement, and it's really a structured improvement process. So, right, how do I then take all the bundle elements? How do I actually implement them and do that? And that's what the model for improvement can help you with. It's essentially 3 steps. So the first thing you want to ask yourself as you're getting started is, what are you trying to accomplish, or what is your goal? How will you know that a change is an improvement? So how are you going to track and learn from that? And then what change can we make that will result in an improvement? And you're really going to use your data to tell you that. And so we go through these 3 steps, and we do that through something called a Plan, Do, Study, Act. And we'll talk about that a little bit more. The nice thing about the model for improvement, and the nice thing about PDSA cycles, is it allows for an iterative approach to testing. So what do we mean by iterative? It essentially means you're repeating a cycle or a strategy that involves a cyclical process for refining or tweaking the latest version of a product, process, or idea. So it really means you're taking something and you're going to give it a try, right? You're going to test it and you're going to see how that works. The nice thing about something being iterative is it takes a little bit of pressure off of it being perfect the first time, and understanding that you're not going to get it perfect or get it exactly the way you want it the first time. But if we use the model for improvement and we use PDSA cycles, we can try ways, we can learn each time that we attempt it, and we can improve it each time we go. So next slide. So interventions are the changes that you will want to do that you'll potentially implement that will accomplish the associated driver. It's the solution or solutions to your problem that will help you to identify high quality interventions. You need to understand your current system. So I know this is really a brief presentation today. We didn't have a lot of time, and I hope that you have talked a little bit about interventions and drivers and maybe some of your other quality improvement sessions. But really the changes are the things these are the verbs or the things that you need to do in order to hopefully get to that goal, or hopefully get that bundle element in place that you're working so hard to do. And before you can even design an intervention or design something that you want to implement, you really need to understand your current system. And that's where you're going to tweak things that work for your system that might not work for somebody else. Next slide. So testing versus implementation, I'm just going to talk briefly about this. So when you are testing or trialing something new, you're typically going to do that. It's usually we say a small test of change or on a small scale. So you are doing one PDSA cycle or one test to see how that element or how that test has worked. And you're going to learn each time you test, you're going to learn a little bit about your system through that through the model for improvement, and you're going to adapt each time around, and you're going to keep testing it. So typically when you're testing something, you might do a number of different PDSA cycles, we'll say, hopefully learning something, one or more things, and tweaking it to get it to where you want to be. We call that testing. Once you get an intervention to a place where you're happy with it, like I like the way that we're doing this makes sense, this is working from our team, our data tells us that we think this is actually going to improve on care, it's going to help us reach our goal, then you're going to implement it. So when you implement something, that means you're making this change a part of the day-to-day operation of the system. It's a permanent change, and it becomes the way that work is done. And would the change persist even if the champion was there to leave the organization? So that's important, and I think that will lead into the sustainability discussion. So once you're implementing a change, we say you're also hardwiring it. That's another terminology we use a lot of in QI science. So you're hardwiring it, you're making it a permanent place. And even if one or more of you leave the organization that was part of all that testing and all that work, we would hope that has become such a part of the daily work that it will remain and will sustain when you're not there. That's testing versus implementation. So I mentioned a lot about this Plan, Do, Study, Act. So the reason that we do PDSA cycles is it reduces the risk associated with change while increasing the probability that change will be effective. So if you're like me, you might work in an organization where not everyone's on the same page, or not everyone has an idea of how we might want to test or implement something. So we start small, and we know that with each PDSA cycle, or each time we try something, we begin to build a common understanding. Right, people are learning with you, they're on this journey with you, so you can build some commonality to understand about how we might want to edit or adjust this implementation so that it makes more sense for others. You're learning from others as you're doing this. It allows you to evaluate cost and side effects. Some of you may have heard in the past a reference about measurement and process or outcome and balancing measures. We also call balancing measures side effects. So it might perhaps by testing something on a really low risk or a small number of patients, we can understand if it led to an unwanted consequence. So that is the nice thing about PDSAs or testing things at a small scale, is that you can learn about those unintended consequences earlier and at a lower risk before fully implementing something where you maybe not have considered it. It allows you to explore theories and predictions. So again, we're going to learn from each one of these cycles. So you might have thought, you might hypothesize that implementing something in such a way is going to lead to X result, and in fact you were wrong, and that's okay, or it wasn't what you expected, right? So that's something that you would learn. So it allows you to test it and make predictions and then learn from it again. We also encourage to do PDSA cycles under various conditions. So for instance, you all work on healthcare, and most of you work in EDs. We know that the ED staffing level on a Tuesday afternoon is probably not the same on a Sunday or a holiday. So we encourage, if you're doing some PDSA testing, to test it in different shifts with different staff and to understand how that implementation or how that practice performs. So you can, again, learn and adapt for the next test. Next slide. This is a visual that talks a little bit more about what you're doing in each of the steps of the Plan, Do, Act, Plan, Do, Study, Act cycle. So in P, that's plan, that's a first step. Objective, really, what is it you're trying to implement, or excuse me, to test, I should say. What are the questions and predictions that you have? You want to talk about with your team who's going to carry out that test, what, when, and where. I typically say the first time you're testing something, specifically in an ED, I'd always do it on a Tuesday. Tuesday during the day, and the next time test it on a Sunday night or test it in other conditions. It's nice when you're planning a new test to test it when you have folks available on site that are knowledgeable and are part of the PDSA planning phase, so that they're able to answer questions. So you're going to then you're going to carry out those plans and you're going to document your problems and unexpected observations. So you probably will have an internal data collection tool that you're going to use. You're going to track how many patients or how many scenarios you tested this out on and what happened each time. And you're going to begin to collect that information so you can study it or analyze it. And you're going to sit down with your team and look at this. Sometimes a test can be done on just n of one is suitable often, right? Let's just do it one time and see what we learn. And the next time, maybe do it 2 times. So you're going to study together and then you're going to act. So typically when you're acting, you're going to decide if you're going to adopt it, which means that this works as is. Doesn't very often happen on the very first time. You're going to adjust it. So you're going to make a tweak and you're going to plan a second cycle or PDSA cycle number 2 and decide how you're going to edit it for your next cycle, or you're going to abandon it. It's very well possible that after one time you realize, oh, this is not what I predicted would happen. Let's scratch it and let's plan a different test. And essentially, if you go to the next slide, I think it shows just how you would do this time and time again. So if you begin on the bottom left, you're beginning off of hunches, theories, and ideas. Many of them are evidence-based. Many of them are, like you said, maybe through bundle elements that you've talked about within this collaborative. Some of them are from literature. Some of them are really ideas on how you think a process might work better. And you can see each time as you go up the ramp, kind of, up the diagonal, you can see you're repeating the PDSA cycle, and over time, you're incorporating your learnings from each previous cycle into the next one. And hopefully, you're going to get to the top right where you're ready to implement a change that's a result of the learnings of your numerous PDSA cycles, and that you believe will result in a change that's an improvement for your team. Next slide. So successful PDSA cycles really just means that you're learning. An unexpected outcome is not a failure. So I think I misspoke earlier when I said that, didn't go well. Really, each time you try it, you're learning something that informs the next cycle. And perhaps it's something you can even bring back to this collaborative or another collaborative that you're part of in the future, where you can share the learnings of things that didn't work. Learning increases the likelihood that the efforts will lead to effective and permanent change. I don't know how many times we think, like those of us that are not at the bedside or not the front line, we think it's going to work great in our mind the way we think it will. But then once we engage those folks at the front line, or once we actually put it in practice, we realize it may not have worked and it won't be sustainable. So the more you can test a process or test an element, it's more likely that it will be effective and it will lead to permanent change, right? And better use of your time, better use of your resources if you test it time and time again. Planning for success is really important. And the key to rapid learning to drive improvement really is the PDSA cycle. That's really the root of QI. And I think on the last slide we have here, go ahead and advance. It's just how quickly to implement. So really the decision to take something that you're testing, implement it, is really based on the team, and it's based on what it is that you're trying to test. So if something is a really simple change and the test was successful, you certainly want at least one PDSA cycle before you want to implement it, but that's really dependent on the team. Sometimes you might have a couple different PDSA cycles that are happening in parallel to each other, and you might be learning to see which of the two works the best. And sometimes they might be sequential PDSAs. So it might be that you decide we're going to implement this PDSA in one area before we spread it to another. It might be that you want to implement it in one hospital before you spread it to other hospitals within your larger health system. The visual on the right is kind of a nice tool that you might be able to use to help your team understand, like, really when you're ready to implement something. So if you have low confidence that the change idea will lead to improvement, you would want to have and you have a really resistant staff, you'd want to test it in a very small scale before you went any further. However, if you look down at the bottom, if you have high confidence that the change idea will lead to an improvement, and there's a really, the cost of failure is quite small, and your staff is ready, then go for it and implement it. So this is just like a nice grade that you can kind of use to assess how much confidence do you have in that initiative, and that will help you kind of in understanding like where your staff is in terms of their readiness, and to decide how largely to test it, how much you want to test it before your team says, and also the risk involved before your team says they're ready to implement. Next slide. Thank you.
Thanks, Mona. So I'm going to talk about next how we sustain these QI efforts. Mona described so amazingly about implementing and how to do PDSA cycles. So once we get there, how do we sustain these efforts that we've worked so hard on? Next slide. So this is some ideas for a sustainability plan. So you need to be able to enter data and measure progress. So with no data, you can't do quality. You need to identify strengths and barriers. You need to implement these interventions and PDSA cycles like we talked about. And you want to compare your performance to SMART aims. So we all set SMART aims in our groups. You want to see, are our interventions getting us toward our SMART aim? And then you want to identify strategies for sustainability. You then want to review the impact of your PDSA cycle in your ED and then report progress to key stakeholders. So these are all need to be part of your plan to sustain your quality efforts. Next slide. So when you're talking about sustaining quality work, there's quality improvement, which is the PDSA cycle. And then you also want to think about quality control. So this is your organization focusing on these day-to-day operations. So you really want everyone to have consistent attention to daily work. So this is really a culture of quality in the whole institution. Really, you need support from not just in your division, not just with this this project that you're doing, but really everyone's looking at things and how to improve them. Next slide. So this is from IHI. They put out a white paper that describes essential practices for sustaining quality. And this includes, we'll go over each one: standardization, visual management, escalation, accountability, problem solving, and integration. We'll go into each one. So next slide. So standardization is really just having specific, detailed, documented standard procedures. These are processes that to define and disseminate your standard work. So basically what to do and how to do it. And these aren't just for your frontline caregivers, but these are for supervisors, higher level managers, executives. This is to minimize confusion and duplication. This is to ensure availability of equipment and supplies and making sure that all the staff knows what to do. This provides this stable support and clinicians can practice within this. Examples are, surgical checklists for people use airway checklists when they're doing intubations. So frontline staff have to be mindful every time thinking about patient care when they do these processes. Next slide. So accountability means a process in place to review these implementation of standardized protocols. And this is essential to understand that the training needs are processes that don't work well. So this can be frontline huddles at the beginning of each workday or shift. So some people are paying attention to what's going on. This maintains staff attention to standard work processes, but it's not really, again, just for frontline staff. So higher level managers should be included in regular participation in these staff huddles so they can monitor and support the care quality and reliability. And this also just gives everybody buy-in to, committing to quality in the organization. Next slide. So visual management is the use of clear, simple displays. Staff need this current clear information about process and performance. So you need simple data displays really at the unit level that show performance on key quality measures over time. And you want to track problems that the team is currently addressing. People need to know where they stand. Are their efforts making a difference? Where do we need to change? The best way to do it is to post it on a board in the workspace where the team can see it. It can often provide a backdrop for huddles, and I'll show examples later. And in many cases, the care team can select measures that are consistent with departmental and organizational goals. It just engages the frontline workers, and you can review and refresh this data daily. A lot of us do this with our door to doc times, our left without being seen rates. So those are ways that people have used this, and you can expand this into other quality projects like sepsis metrics or whatever you're working on, our ED stop measures. Next slide. So problem solving is the next one. So these are methods you need to have methods for improvement skills so that staff can address issues. So you want to have structured methods for identifying problems or diagnosing problems. So things like flow diagrams, root cause analysis, cause and effect diagrams, and testing changes. This is really allows staff to address issues as they arise and confront routine problems on a routine basis. So huddles can also provide this forum for raising and triaging quality problems, disposing of simple problems, what can we solve today, and then escalating complex problems that may require a formal QI project. Next slide. Escalation allows frontline staff to identify problems and present those that need action to management. And there should be clear criteria to distinguish issues that should be escalated to higher management. So what can we handle internally, and then what do we need to escalate? So things that they can't solve immediately or that require interdepartmental coordination, you can escalate to the appropriate level of management that can help commission improvement initiatives. And that becomes part of the standard work for both frontline staff and managers. Next slide. Integration is active communication and consistency between management, staff, and across departments. So this is really essential if the organization is going to deliver on these quality promises. So for every patient, every time, it's not just going to be in the emergency department, it's going to cross all departments. You need to have a formal system for coordinating these strategies with quality goals, prioritizing, how do you initiate and manage improvement initiatives, and how do you build this improvement capability, and much more. So this goes into a lot of the how does quality control integrate into your quality improvement projects? You need to have support from your institution. You can't just operate in a vacuum, essentially. Next slide. So this is just an example from the white paper. So this is a key driver diagram talking about how you can create this conditions to effectively oversee quality improvement. And your impact is that you want to provide reliable, safe, timely, effective, efficient, equitable, and patient-centered care, which are the 6 goals of quality. So if you just look at this key driver diagram, you can see, so there's the quality control, quality improvement, and then establishing this culture of high performance management, how there's this interplay among these. And then on the top, you can see the secondary drivers, those 6 things that we just talked about. And then you can go further on. But really, it's this really kind of complex interplay between your quality improvement projects, your division, and then departments, and then across departments, and then how really higher up management has a lot of influence over this, and you have to have a lot of interaction with them and interplay to get support. Next slide. So this is an example of a planning worksheet. So this is something that you can use as a tool. It offers these 5 areas to consider when you're planning for your sustainability, for your improvement efforts. So things like measurement, what will we continue to measure? What are we going to stop measuring? So what are the most important things? How are we not going to duplicate efforts? What are you going to do if you see a negative signal? So what if things are not going right? What is your plan? And then Mona touched on this, who will own the new standard work? So if somebody leaves, who's going to maintain? And is the person that's going to continue this, are they engaged? Are they on board with the improvements? You want to have the right stakeholders, the right personnel working on these things. And then we'll talk a little more about communication, but knowing how you're going to communicate about the change and who are going to be the messengers. How are you going to support individuals to perform these processes that we say are the new right way, this new way that we've demonstrated has improved care. And what type of trainings are you going to use? There's always turnover in personnel. How are you going to orient people to what we're doing? And then Mona touched on this also. How do you hardwire the change? How do you make it hard to do the wrong thing and easy to do the right thing? And how do you reduce reliance on human memory? We talk about things like order sets or checklists, things like that to reduce error. And how do you standardize it? Do you need new documentation? Do you need new resources? Do you need to work with IT? And then assessment of the workload. So are changes increasing the overall workload to the system? And if so, how do you decrease that? How do you make this feasible and possible and desirable for people to implement this change? Next slide. So we'll go over a couple strategies to maintain engagement. So you really want to demonstrate that you've improved clinical care and positive impacts on the patient, and you want to secure buy-in from your clinical staff. So people aren't going to want to do this if they don't think it's helpful. Sometimes it seems like it's more work depending on what your quality project is. You want to disseminate your evidence to key stakeholders so you have their support. You want to encourage medical and admin staff to participate in education on quality, circulate your research findings, and communicate support for QI methods and projects. So you want to really create this culture of quality. Next slide. So communication is going to be key. You want to have regular communication. You want to make a plan. So you need to decide what type of communication are you going to do? Are you going to have newsletters? Are you going to provide updates at your meetings? We had a quality minute at our faculty meetings. You can come up with a catchier name, but just updating staff about quality efforts. I know when nurses have their daily huddles, they often talk about these things. Who is the person responsible? Is it going to be the director or the project leader? Who's going to disseminate this communication? And then how often do you want to report it out? Is it going to be monthly, quarterly? In some instances, it might be daily, like when we talk about our ED metrics. And then who is your targeted audience? So this might change depending on the communication. So is it just to your ED staff, or is this to your C-suite to demonstrate what you've been doing? Next slide. So you want to be able to present the data. So this is just an example of a run chart. So essentially you're documenting, you're graphing out your PDSA cycles. And so this is sort of left without being seen chart as an example. So after each PDSA cycle, what difference are you making? You want to be able to present the information graphically so that people can quickly, easily see the changes that you've made. Next slide. These are examples of huddle boards. We talked a lot about that as strategies for sustaining quality efforts. So really, these are just examples. People do it in different ways, but it should be something visual that people can see. And a lot of times, depending on the project, having a daily huddle, talking about different quality efforts, this can orient people. And some people do it every shift. Some people just do it in the mornings. It really depends on your institution and what your project is, but these can be really helpful with keeping people engaged and oriented to what you all are doing. Next slide. You want to also have messaging ready. So you really want a 5-minute elevator pitch so an elevator pitch is really like, if you're stuck in an elevator with somebody that's important, like you run into your CMO in the elevator and you want to just give them a quick, this is what you should support. This is the great quality project I'm working on. You can practice this pitch. They usually say probably a little shorter than 5 minutes, but if you have 5 minutes, you can use your 5 minutes. Just like a quick and dirty like summary of what you're doing with some data points can be really effective. People don't often have a lot of time to listen to a long presentation. If you do have the opportunity to present, having at your ready a fact sheet or slide deck about your project, and then tailoring your message to who you're talking to. So are you talking to clinical staff? Are you talking to the C-suite? Are you talking to external stakeholders? Next slide. And then really following up, you want to make sure to keep sharing your data with key stakeholders and incorporating their feedback. You really need to engage people that have influence over your ability to carry on these quality projects. You need support. And so keeping them engaged with the data, having regular meetings, regular follow-up, including them in on the messaging and the communications is really key. I think that's my last slide.
Thank you so much, Mona and Cheryl, for your insights and expertise on translating QI science into sustainability planning. So now that we've had our brief presentations, we are going to move into our breakout groups. So before we do that, I wanted to mention that we are combining breakout groups 1, 2, and 3. So 1 and 2 have previously been together, but now we're combining 1 and 2 with 3. So if you are part of Saturday Night Fever, Rural Rules, or Allies, so again, breakout groups 1, 2, or 3, please choose the first breakout option. when they pop up. And additionally, we are also going to be combining groups 4 and 5. So if you are part of the Fantastic Four or the Fabulous Fivers, when the breakout group options pop up, please choose the option that says Fabulous Fivers and Fantastic Four. And that is where you will go. So again, we will be in our breakout groups for about 40 minutes. And then our report out when we come back is going to be about next steps that groups are planning on taking to move forward with their QI project. So we can show the next few slides, which are going to present which breakout group each team is assigned in. If anyone has forgotten which group they're a part of or needs a reminder of where they're going. So please find your team, and when the breakout group options pop up, you can choose. Okay, now I see them popping up for join a breakout group. So if you scroll down, if you are a part of 1, 2, and 3, choose the first option. 4 and 5, choose the second option, and then the rest are remaining as normal. And we will see everyone when we come back to the large group. Again, welcome back. As stated before, we are going to move into the report out section now. So for each group, please tell us some next steps that some of your groups were talking about planning on taking their QI project and moving it forward. We can move on to the next slide, please. So this is going to be the order of our report outs, and I can take it first for groups 1, 2, and 3. So we had such amazing conversations in my breakout group. We were talking about a range of projects, from having policy changes to lower screening ages, telehealth psychiatry programs, resource packets being created and distributed, and many more. So it was really exciting to see how far these projects have come since February when we started this. So to report out on some next steps that my group is looking forward to taking with their project and team. One thing that we talked about was keeping momentum going despite busy schedules. We talked about continuing to educate ED staff and making sure that ED staff is continuing to remember to hand out things like resource packets and other items that are being created, and just kind of keeping up with the new change strategy implementations and making sure to keep integrating those into their tasks. Lastly, we talked about data collection, and those are some of our next steps that our group were talking about. So I can pass it off to breakout group number 4.
I guess it will be me, right? This is Anna. The one group that had reported off had focused on looking at measuring of the effectiveness and outcomes. This group particularly was focused on DC safety planning, discharge safety planning, and one of the measures is facilitating discharge planning in the ED, diverting from the admission if possible, and performing those 24 to 48 hours reassessment is an intervals and opportunity to reassess the need for admission. So that's one measure of outcome. Another measure we talked about is having that intervention as a evaluation for parent and patient satisfaction. And looking at opportunities with that. And one of the sustainability measures was suggested that I think that, and correct me guys, I think that's the hospital already is on the way to creating or had created is behavioral health committee that can help facilitate those discussions forward. That's it for group 4.
Yeah, the only thing I was going to add was that the hospital that the person that's been working on it has done a really tremendous job despite a lot of barriers, and was able to find a way that actually the tool already existed in their EMR. So probably a really big win in regards to that.
Thank you.
Thank you so much. Group 4, we can move on to the Fabulous Fivers.
So we were combined today, but I'll chime in for Fabulous Fivers, and Tisha, feel free to add comments. But it's been an incredible journey, and listening to all these people's incredible successes across their institutions, and in some cases across the larger healthcare system. Among the Fabulous Fivers, the focus has been from implementing universal screening in the younger population, some as low as 5 and up, some 8 and up, to working on standardized risk assessments and integrating those into the EMR platform, beginning to look at methods of sustainability that Dr. Yanger talked about earlier, like quality control, and beginning to chart and track ongoing data or audits every month. And then lastly, one of the teams is really working closely on ED-based interventions and how to really support the families who are boarding, from meals to showers to therapeutic techniques. But just really an amazing impact on this community. And I'm going to turn it to Tisha to see if she has other thoughts and comments to add.
Thank you. Nothing major to add. I think that pretty well covers it. I think one thing that we talked about was engaging other systems, and Kate spoke a little bit to, how do we bring things out to larger, like the overall system versus just your hospital. And then we also talked about sustainability with access to outside resources.
Thank you so much, Fabulous Fivers, for sharing. We can pass it on to the Sunshine Mood Movers.
So our groups both today focused on ED-based interventions and looking ahead, wanting to ensure that all their staff is trained and aware of the resources that they've put together and how to implement them, whether that be, different shifts or even whenever you have to have different staff working the ED that aren't normally there, ways in which that they could also be aware of those resources. Looking to get past that feeling of survival mode, and also moving forward, extending child life coverage. Our sites both really identified the role that could play and the benefit it could provide to their patients and staff, but overall improving the comfort level of all disciplines with the resources provided by Child Life.
Awesome. Thank you so much for sharing, Casey. Okay, we can pass it along to Group 7, CSIS.
I can talk a little bit about our discussion. We have great projects. Some of our groups are looking at bundle 4, discharge planning, and then some are doing universal screening. So we talked a lot about how to incorporate universal screening, getting buy-in, how to do it with tablets or electronically, and like troubleshooting how to do that. And then with discharge planning, one of our groups is making a video, which is really cool. So talking about their process, that and doing IRB, and then also incorporating surveys of families and caregivers. And so really getting information, directly from the patient population, and then also how this might be helpful for another group who's looking at firearm safety counseling and how maybe they could incorporate surveying patients in that also. So really cool projects that are, not just looking at one thing, but really expanding out, how this can help our patients. And so we talked about barriers, especially with things like with the EMR and getting stakeholder buy-in and all that, but really so much progress and like really amazing projects.
So awesome to hear. Thank you, Cheryl, for sharing that. And then I'm not sure if Vera is still on, but Laura, did you have any other input for?
Yes, I'll add one thing. I think there's interest in universal screening across the board. Some children's hospitals and others have implemented it. There's also desire to implement it, but concern about the need for staffing and training, and maybe getting overwhelmed by it. But there was a lot of reassurance amongst the hospital teams that had done it, especially for 3 years or more. And they talked about how at the beginning it was hard, but then they got buy-in across the hospital, and it made the situation better. And they also talked about screening both in the ED and once a patient was admitted, even in surgery, and how they would handle those kinds of things. So I think in general, universal screening, while people were a little bit tentative about taking it all on, those hospitals that had implemented it were in strong agreement that it was definitely worthwhile.
Perfect. Thank you so much for adding that, Laura. So I can go ahead and pass it on to the suicide squashers and pass it over to Angela.
Hello. So the suicide squashers, we had a lot of wins. Most of our groups are either in bundle 3, which are ED-based interventions, or in bundle 4, thinking about the discharge process, and once patients are discharged, kind of how we're following up. So I think some of the wins, I saw across all of them a good use of the PDSA cycle of trying to implement something and then kind of identifying that maybe we needed to make a little bit of a shift. One group implemented ED-based intervention and then realized that a part of the system that they didn't think about, the transfer center, actually was a stakeholder, and so that they needed to engage them to figure out how that change impacted the work that they did. And so they had to put a pause on their process to make sure that they're engaged with that transfer center and that all the different stakeholders understood what was happening and agreed. I do think a big win was that someone was able to get a majority of the hospitals in their area to no longer need baseline labs. So that's exciting for the kids in that area. A big win. And then the other ones were thinking about, most everyone had finished their or implemented something. There's the sustainability was kind of what's going to be the next step. So one group found that the follow-up, people don't answer phone calls as much. So in their PDSA, they found that the My Charts were being, when responding, they were responding via the My Charts. And so I think that kind of identifying what sustainability, can we make that automated? How do we gauge how effective some of our interventions are? So I was really impressed with what all the different groups were doing, and how much they've been able to implement since the beginning. I mean, one group had a whole list of things that they were able to implement, and that group, since they've implemented so much, is really looking towards sustainability with champions. And how are they going to make work groups, and how are we going to sustain that and infuse that into future trainings for new staff and skills labs and things like that for ongoing staff. So yeah. Hannah, did I miss anything?
No, I think you captured everything.
Perfect. Thank you so much, Angela and Hannah. Thank you for sharing all of that. That sounds really amazing. And again, it's so exciting hearing how far everyone's come since February in such a short amount of time, but such impactful, amazing projects are being implemented, and it's really exciting to see. So thank you everyone for the report out. We can move on to the next slide. So some next steps going forward. After this session, you will be receiving an email from me containing an ED Stop Suicide QI Collaborative post-collaborative final evaluation form. So this evaluation form is going to ask questions regarding information that's important for us to hear about your QI projects, just to have it, make sure we have everything on file. We also want to hear about your opinions regarding the past fireside chats and collaborative learning sessions, and also your thoughts on different aspects of the collaborative overall. So this survey should not take more than 10 minutes to complete. Every team member, we are requesting every team member please complete the survey. So if people are missing from your team today, please let them know that there will be a post-collaborative final evaluation form being sent out, and to please take that. So we're going to use this form to improve future collaboratives, and also track the clinical care changes that have happened throughout the collaborative. So we only have one collaborative session left, which is going to be on November 2nd from 12 to 1:30 p.m. Central Time. We hope to see lots of representation from each teams, as this is our last collaborative session. We would love to see as many people as possible. So during this session, we are going to have around 10 teams share their QI journey, outcomes to date, and things of that nature. And then during this final session, we really just want to celebrate everyone's QI project journey and all the hard work that everyone's put into this as a whole. So we're going to stay in the large group the entire time. There aren't going to be any breakout group sessions. So today was our last breakout group session. Next time we're going to be in the large group the entire time together. And then lastly, moving forward, just keep pushing on with your QI project work. So right now we can launch our session evaluation mini poll that we always do at the end. And then after this, we will get those nursing and social worker CE and CEUs up too. So if you could stay to please complete this poll, we would really appreciate that. And then we will get the nursing slide and social work slide up and those direct links into the chat for you. Thank you so much, everyone, for completing this. Here is the nursing slide. You can scan the QR code to take you to the next place, or we will have the direct link be put in the chat soon. Kate, to answer your question, we do not have all teams set in stone yet. So if your team would like to volunteer to present at the final session, you can reach out to me. And we would absolutely really appreciate that. Thank you, Casey, for putting the nursing and social work direct links into the chat. And if there are no further questions, or anyone would like to go back to see a previous slide, that is all we have for you today. We really appreciate you joining. Thank you so much, and we look forward to seeing you during our final session on November 2nd. Okay, I think it's just our team here left. Okay.